it's me, Elaf shamari, and today we will talk about the upper GIT bleeding. It's one of the cases that you will see it in the emergency room. So we will discuss today the causes, the signs and symptoms, and also management. Okay, now let's discuss causes. The causes of upper GIT bleeding is first one is PUD. It's mean peptic ulcer diseases. It's about 50% of all cases. Second one is gastroduodenal erosion. It's about 15% from all cases. Third one is esophagitis. Also, it's come as a symptoms of upper GIT bleeding. Then we have something called Miller-Weiss syndrome. Also, it's presented as a bleeding, then varices, esophageal varices in the patient who had chronic liver diseases. The last one is the arteriovenous malformation, also malignancy, and there is also trauma. Okay, here's the causes. Then we had another thing we will talk about is the sign and symptoms. How the patient will come to you in emergency room. First of all, maybe patient will be a chronic liver disease patient. So this is important to know from his past history. Then the patient will come complaining of hematemesis, which is mean vomiting blood. And you have to differentiate between hematemesis and hemoptysis. Hemoptysis, it means he's coughing blood, while hematemesis mean he's vomiting blood. Also, we have melena. Melena, it means black tear stool. And those two are most important symptoms patient of upper GIT bleeding will come with. Then patient, he will complain of dizziness, especially postural one. And also patient will complaining of hypotension, and then he's tachycardia. But if he's on beta blocker, he's not tachycardia. Then decreased GVB, you can notice. Also decreased urine output, but urine output is not important one because it's an emergency case. So the thing that you will notice is hematemesis or melena. The patient complaining of also decreased blood pressure and tachycardia, maybe GVB, you could notice this. And then the management. The question is how to manage patient had upper GIT bleeding. This is so important because it's a life-threatening emergency case. Now, first thing you have to do or you have to know this case, it's a group work or it's a teamwork. So here we had doctor and also we have assistant and nurses. All these people are helping to cure the patient. Second thing is you have to know if the patient is stable or not stable. Not stable mean patient in shock. So you have to know the signs and symptoms of shock. You will, when you touch his extremities, such as hand, foot, or even nose, you could notice he's cool or even cold. The pulse rate is a tachycardia over 100. Blood pressure is hypotension, especially the systolic, and the urine output, it will be less than 3 ml per hour. So next thing you will do after knowing if the patient is stable or not stable is try to reassure the patient if you see the patient is stable. Then you have to be careful about the circulation. Open two large line about 14 to 16 size of the cannulas, and then try to give the patient something called fluid resuscitation. Fluid resuscitation, give normal saline from 1 to 2 liter and try to prepare 6 units of blood and also fresh frozen plasma. Then we need after circulation, we have to be careful about the breathing, his lung. So what we have to do, the patient need intubation, so try to do intubation. and then try to do nasogastric tube, because nasogastric tube just to prevent aspiration. Okay, I just would like to say one more thing. When you prepare a unit of blood, try to do cross matching and grouping. This is so important and necessary. If you can't do it, or there is no enough or there is no the same group of this patient, so you have to give O negative blood group. This is will help a lot. Then send the blood sample to the lab for urea and electrolyte, liver function test, and also clotting screening. This is so important. Then, after we talk about airway and how you protect airway, CVB is central venous to measure central venous pressure. And after this, you have to give some drugs such as vitamin K, so important for the bleeding. And also we have ectoriotide, especially in the patient with the chronic liver diseases. Try to go from 25 to 50 micrograms, 25 if the patient is elderly, 50 if the patient is still, young. Then a vasopressor. Okay, I just would like to say something about vasopressor. It is actually working on the receptor. It is or it's acting on the smooth muscle and lead to vasoconstriction. Also, it is antidiuretic effect. It's contraindicated in the patient who had coronary or even supplanting vasoconstriction. Then, after vasopressin, you can give to the patient omeprazole just to prevent the stressful ulcer. After all this stuff, try to do catheter to measure the urine output. It has to be more than 30 ml per hour. And this is one of the signs that patient is on progress. Then the vital sign, try to measure it every 15 minutes when the patient is stable, then do it hourly. After that, do endoscopy. Now, also there's one more thing. If there is no endoscopy or if the patient is still bleeding, try to do something called Sanjustakin Blackmore tube. It is so helpful to stop bleeding. Now, one more thing I would like to talk about is the endoscopy. Within 4 hours, if your patient is stable, so do it. But if your patient is not stable, so wait from 12 to 24 hours. So this is all I have about GIT bleeding. See you. Bye bye.